All right, let's talk about hematopoietic proliferative disorders with an emphasis on chronic myeloproliferative disorders and plasma cell dyscrasias. So first, we're just going to go over general overview of hematopoietic lineage. Talk about the hematopoietic cancer family tree, looking at leukemias versus lymphomas. Then we'll dive a little bit more into detail for the chronic myeloproliferative disorders and the plasma cell dyscrasias. So looking at hematopoietic stem cells, this branches off into two categories: myeloid and lymphoid progenitors. The lymphoid are, for our purposes, just going to give rise to the T and B cell lineage. The myeloid will give rise to the basophil, neutrophil, and eosinophil, mostly what we're interested in. So these are also sometimes known as granulocytes. So we're a little bit less interested than most of the other things here. So a little summary of this is just the myeloid, myeloblast. So blast just means immature. And again, this is eosinophils, basophils, and neutrophils. Neutrophils, far and away, though, the most predominant form here. And then B cells and T cells, ignoring natural killer cells. So we'll circle back to that at the end. But leukemias are really just a cancer, proliferative disorder of the bone marrow, while lymphomas are a proliferative disorder of the lymph nodes. So you can really break down hematopoietic proliferative disorders into four different categories. Leukemias, so in this case, these are in the blood and in the bone marrow. B cell, or it's going to be more than T cells. Specifically, it's lymphoid, but it could also be myeloid. Malignant because it can metastasize and spread. Lymphomas also would be categorized as malignant. Now, these cannot be myeloid. These are only lymphoid, and like we said earlier, they're in the lymph nodes. And then the plasma cell dyscrasias are going to be in the bone marrow, and as plasma cells are really just activated B cells, they are characterized by lots and lots of antibodies, lots of immunoglobulins. Lastly, we have the chronic myeloproliferative disorder. Notice that this is the only non-malignant proliferative disorder. So this will be mature myeloid cells only. So we have a combination: lymphoid only, B cells only, and then mature myeloid only. Basically, neutrophils. Again, neutrophils are by far the most common mature myeloid cell. So now breaking down into all of the categories and subcategories. ALL, AML, CML, CLL. So this is, acute and chronic and lymphoblastic and myeloid, and then hairy cell leukemia. The lymphomas can be categorized under non-Hodgkin's or Hodgkin's. The non-Hodgkin's has several categories. We can break it into B cells, B cell non-Hodgkin lymphoma, Burkitt, diffuse large follicular mantle marginal primary CNS. And then T cells is less common, but we have adult T cells and mycosis fungoides, which can progress into a type of leukemia known as Sézary syndrome. There's a couple of subtypes of Hodgkin's, but those are less important. Plasma cell dyscrasias, there are three: multiple myeloma, MM, Waldenström macroglobulinemia, and monoclonal gammopathy of undetermined significance. The chronic myeloproliferative disorders, we have polycythemia vera, myelofibrosis, essential thrombocytopenia, and CML. The reason CML is underlined is because it technically can be categorized as leukemia and also as a chronic myeloproliferative disorder. This is probably the categorization that you would be more familiar with. So looking at leukemia etymologies, hopefully it's still on. All right, so looking at leukemias, ALL. So A, acute. Acute really just means that these are immature, so they're going to be called blasts. Acute leukemias arise really rapidly. The second L is for, not leukocytic, actually, it's for lymphocytic. Lymphocytic, so this could be a T or a B cell. Again, we said that usually it's a B for both leukemias and lymphomas. And then lastly, leukemia. So all of these four leukemias are going to have the last L represent leukemia. Leuc just means white blood cell. Again, this can be myeloid or lymphocytic. And then emia just means in the blood. So again, acute, rapidly rising blast. Now we have M for myeloid. So this will be myelo, and specifically blast because it's the acute version. And then again, of course, leukemia, they all have this. Chronic. Chronic is going to be a mature, more differentiated cell. It's going to be slower forming. And in this case, because it's a chronic, we said that the chronic is going to be the neutrophils as opposed to earlier where it was the myeloblasts. And again, still leukemia. And lastly, C for chronic. mature, slow forming. And again, L for not leukocytic, but lymphoblastic. And then the lymphocyte could be T or B cell, usually B, and leukemia. So the big picture here, this is really just on the spectrum of age. I like to think of so this is going to be young, and this is going to be old. So I've actually gotten a little bit of mixed data on this. I've looked into this. So what I'm very confident in is that ALL, so this is, for the most part, this is, you can think of the M's for medial. M for medial or M for middle. I guess you can think of the L's for lateral. But these two go in the middle. And then if I'm categorizing between these two, A becomes before L. So that's how you can remember that this is the first one, this is the second one, this is the third one, and this is the fourth one. So what I'm very confident in is that the ALL is the kids, and the CLL is the eldest. I've seen some data to support the idea that AML is in their 50s and 60s, and maybe CML is also in their 50s and 60s, but maybe a slightly older age. So it's one way you can think about it. Alternatively, you could just think of these are about the same age, 50s and 60s. So kids, 50s and 60s, and then CLL is going to be 60, 70, and older. Cell type, we already went through this: immature lymphocyte, immature myeloid, mature myeloid, and mature lymphocyte. Specifically look for our rods. I think of A for our rods here, and then M for myeloperoxidase. So our rods are really just precipitated myeloperoxidase. So these two things should go together. Our rods are really just myeloperoxidase that is precipitated. The stain here would be TDT plus. So this is going to help immature lymphoblasts generate diversity through recombination, so it makes sense that they have TDT. CD10 is also going to be a marker for immature lymphoblast, specifically of the B cell origin. In the translocations, we have 1221 and 922. 922 is also the Philadelphia chromosome, so we do see that here in CML. This is mainly where you're going to see 922, but you see a little bit of 922 over here. 922 for ALL will be worse prognosis, often for adults, and then the 1221 is going to be the slightly better prognosis often for kids. So I think of this as a mirror. So 1221, this is a mirror, and a mirror for minors. Excuse me. Mirror for minors. 1517, this is not all AMLs, but some AMLs are acute promyeloid leukemias, and they will have this particular chromosome, which we'll talk more about later. Lastly, the smudge cells are going to be shown on the CLL. But again, these are the main four. We also have hairy. So hairy is going to be mature B cells. Specifically for the histology, you look for the hair-like projections, and for the staining, you look for TRAP. Lymphomas, so non-Hodgkin's is the worst prognosis. Hodgkin's is the better prognosis. Some people might say if you want to have one of the lymphomas, it's better to have the Hodgkin's. That is the good cancer. If you have a swollen lymph node and it's painful, it's probably an infection. If it's not painful, it might be a cancer. Hodgkin's also is a bimodal distribution. So really young people, really old people, often not middle-aged people. Most important here is the young. If anybody shows up on your NBME with they're young and they have a swollen lymph node, it's more likely to be a Hodgkin's lymphoma. Non-Hodgkin's is typically going to be older people. CD15 and CD30, so I think a 15 times 2 is 30. And where does the 2 come in? Because these Reed-Sternberg cells have these giant cells which are multinucleate, multi-lobed here. So I think of 1, 2 times 15 is 30, and just all of that kind of comes together. Now, the Reed-Sternberg cells look very much like, you squint your eyes, kind of looks like an owl. So the owl eye Reed-Sternberg cell is pretty easy to notice, and that the histology. Yeah, cool. Leukemias, you can think of as lemonade. So leukemia is a cancer of the blood, so it's in the fluid. Lemonade is a fluid. However, at the same time, we might have some seeds in a lemonade. And you could take these seeds and you could plant them and you could grow a lemon. So lemon would be the lymphoma component. And you know what you can do? You can take those lemons and you can squeeze them out and you can make some lemonade. The point here is that leukemias can become lymphomas, and lymphomas can also become leukemias. Taking a look at these second two categories, plasma cell dyscrasias and chronic myeloproliferative disorders. Let's go ahead and start with this one. So plasma cell dyscrasias, for the most part, plasma cells are just making tons of antibodies, so we should look for lots and lots and lots of antibodies. Specifically, this will be an M spike on a gel electrophoresis. Let's go ahead and take a look at this now. So this is what a normal gel electrophoresis will look like for plasma cell proteins. Albumin is the most abundant protein in the plasma, so we have this large spike here. This alpha and that alpha goes with these particular proteins, and this goes with this protein, and these go with these proteins. Notice this is IgA, IgM, and IgG. Most importantly, we're going to be looking at IgG and IgM. But if you have too much of some antibody, it's most likely going to be in this gamma category. And so this would be a normal in green, and then in red, you get this large spike around the gamma section. This is called the M spike, and it's associated with any of these plasma cell dyscrasias. Most important is going to be the multiple myeloma. And people say that you look for the Crab syndrome. So what are the Crab syndromes? So remember that the main point of these are that we are overproducing antibodies because we have sort of a B-cell cancer. So this excessive monoclonal IgG production. So this first one, if I have excess IgG production from a B-cell cancer, I'm going to have decreased production of normal IgG. And if I have decreased IgG normally, I'm going to have an infection. So C for chronic infection. At the same time, excess IgG production, and these are the irregular, non-functional IgGs, but nevertheless, there's still way too many proteins in the blood, and these proteins are going to be damaging to our kidneys and our bladders, and so we have a lot of renal failure associated with this. This is going to cause the clinical presentation of thirst, polyuria, people peeing a lot, and you'll find Bence-Jones, which are just the light chains of the IgG overproduction in the urine. Also note that so BG, the Bence-Jones proteins, is something you should look for. And rouleau, these kind of look like a bunch of poker chips stacked up. So antibodies are going to agglutinate and bind red blood cells together. And too much antibodies in the blood is going to bind all of these red blood cells together in this very specific pattern. So this is what's going on here. If I have B cells overdividing in the bone marrow, I'm crowding the bone marrow, which means I cannot make my red blood cells and I cannot make my platelets. So you will have fatigue and pallor also as clinical symptoms. And increased bone turnover. If I have cells, we saw earlier, if cells are dividing too much, those cells are also going to die a lot. And osteoclast activity might be up, and this will cause lytic bone lesions. And this can cause, this is going to be more often in the axial and the appendicular, but this will cause back and rib pain. And the destruction of all of these cells is going to cause hypercalcemia, spilling all this calcium into the blood. Hypercalcemia is associated with nausea, constipation, and a bad appetite. So monoclonal gammopathy of undetermined significance, this is really just a pre-multiple myeloma. And it's an overproduction of any IgG type. So typically this might lead to this. A Walden's trend macroglobulinemia is specifically an overproduction of IgM. Recall that IgM has these 5 antibodies really rolled up into one. So it's going to be particularly good at agglutinating and bringing the red blood cells together. This is going to increase the viscosity of the blood, causing a hyperviscosity syndrome. So we can think about, again, IgG, because it has all these 5, is particularly sticky. Presentations for hyperviscosity or headaches and blurry vision. All right. Lastly, myeloproliferative disorders. So again, we have 4: polycythemia vera, myelofibrosis, essential thrombocytopenia, and CML. But remember that CML is only technically one of these. It's probably better to think of this as a leukemia. So polycythemia vera, also known as primary polycythemia, we have too many red blood cells. All of these, except for CML, will be associated with JAK2. So this is a JAK2 mutation, as opposed to secondary polycythemia, where I have too many red blood cells because I have a pheochromocytoma or some sort of kidney tumor, which is overproducing EPO, stimulating excess red blood cell production. Presentation here is aquagenic pruritus, which is where you get particularly itchy after a hot shower. and hand-foot syndrome, also known as hand-foot erythromelalgia, which is a burning pain and red-blue discoloration, specifically due to vaso-occlusion. So here's a picture here. Myelofibrosis, so we've increased fibroblast activity in the bone marrow, and if my fibroblasts are dividing too much, then it crowds out the bone marrow, and if I do a bone marrow biopsy or extraction, it's going to be a dry tap, meaning that you can't really pull cells out of the bone marrow like you normally would. The bone marrow is crowded out. You can't produce anything that you need. The organs that step up to the plate to try to produce hematopoietic stem cells, so it should be the bone marrow only that's making hematopoietic stem cells, but your liver and your spleen will actually try to moonlight as hematopoiesis organs. Also the skin a little bit. So you might get enlarged liver, spleen, and also this blueberry skin, which is the hematopoiesis occurring outside of the normal bone marrow. And you get these red blood cells that are teardrop shaped. Essential thrombocytopenias, we have too many platelets. These platelets might be large and deformed, so you can see that in histology. CML, we again said, is a leukemia. Too many granulocytes. Now, CML, chronic, means mature. M means myeloid, so the myeloid leukocytes. And again, this is basophils, eosinophils, but mostly neutrophils. These are by far the most common. This is associated with the Philadelphia chromosome. And you can remember that for Philadelphia chromosome together is 22 letters. And I remember that as the second chromosome for this translocation. So just to kind of summarize all of this up, if we look at ALL, A for acute. Acute means we're looking at the blast. If I'm looking at the blasts and it's L, it must be a lymphoblast. So I'm looking at the lymphoblast here. Again, I have A, so I'm looking at the blast, but now it's M, so I must be looking at the myeloblast. Then we have CML, which means I'm looking at the differentiated ones. So at the differentiated ones here, and we said specifically it's probably going to be the neutrophils. So look for a high neutrophil count. CLL, so C again for differentiated and L for lymphoblastic. Specifically, it's going to be the B and the T's, ignore the natural killer cells. We said that B is more common than T. Hairy is specifically only going to be B. We have lymphomas. Lymphomas are typically going to be B or C, but often with B. Plasma cell dyscrasias are going to be B, which is matured and differentiated, activated into a plasma cell. And the myeloproliferative disorders, which are the mature granulocytes, and the mature red blood cells and the mature platelets. And we said that this was polycythemia vera, and essential thrombocytopenia, and myelofibrosis as well, not shown in this particular picture. Great, on to leukemias.